Welcome to This Week in Pulmonary. This week, we're covering 10 notable papers spanning biologics and exacerbation biology in COPD health system inequalities and continuity of care, and new imaging and oncology data across cystic fibrosis and lung cancer. Let's dive in. We start with COPD and the type 2 inflammation story, where CHEST published a matching-adjusted indirect comparison from Bourbeau and colleagues, asking a question every clinician now faces. Mepolizumab or Dupilumab for the patient with eosinophilic COPD. There is no head-to-head trial, so the authors pooled individual patient data from the 3 Mepolizumab trials, METREX, METREO, and MATINEE, reweighted those patients to match the baseline characteristics of the Dupilumab Boreas, and across both definitions of chronic bronchitis, there was no statistically significant difference between the two agents in the annualized rate of moderate or severe exacerbations, and no significant difference in quality of life measured by the St. George's questionnaire. This is indirect evidence with all the usual caveats about unmeasured differences between trial populations, but the practical message is that choice between these two biologics can reasonably rest on comorbid type 2 disease, dosing, access, and cost, rather than on a presumed efficacy gap. Staying with COPD, Respiratory Medicine published a paper that pushes back on how we triage exacerbations by severity. Zhou and colleagues followed just over 700 patients from the early COPD cohort in China with complete annual spirometry over 3 years. Patients who had any exacerbation, including mild events treated only at home, lost lung function faster than those with none, with an adjusted difference of about 13 milliliters per year in post-bronchodilator forced expiratory volume in 1 second. Crucially, the direction of effect held in mild to moderate disease and in the gold A group, the very patients we tend to reassure. If confirmed, this argues that a home-treated flare is not a benign event and belongs in the risk conversation. 2 other COPD papers add prognostic texture. In the International Journal of COPD, Co and colleagues analyzed nearly 30,000 newly diagnosed older adults in the Korean National Insurance cohort and found that fragmented outpatient care, measured by low continuity of care indices, was associated with roughly a 60% higher risk of exacerbation-related hospitalization over 3 years and about a quarter higher all-cause mortality. The finding was consistent across 4 different continuity indices, which is reassuring, though residual confounding by illness severity is hard to exclude. And in the same journal, she and colleagues used the MIMIC IV intensive care database to show that in critically ill patients with both COPD and atrial fibrillation, a higher red cell distribution width at admission tracked with, in hospital, 28-day, 90-day, and 1-year mortality in a graded fashion, with the top quartile carrying roughly 2.5 times the odds of dying in hospital compared with the lowest. That is a free number already on your complete blood count, but it is an adjunctive risk marker, not an action item. The second theme is who bears the burden of chronic respiratory disease, and Thorax published a large population study that should sober anyone who assumes inequalities are narrowing. Whitaker and colleagues linked English primary care records for more than 7.5 million people with asthma and over 1 million with COPD to hospital and mortality data from November 2019 through March 2025. Exacerbation rates were about a third higher in women than men for both conditions, while all-cause mortality ran higher in men. The deprivation gradient was the striking finding. People in the most deprived decile had roughly double the exacerbation rate and double the mortality in asthma compared with the least deprived, and in COPD around 2/3 higher exacerbations and about 40% higher mortality. Regional gaps between the Northeast and Southwest persisted, and outcomes varied by ethnicity. Despite years of policy attention, these gaps have not closed, which matters when we design follow-up pathways and decide where to concentrate case finding. Turning to imaging and risk stratification, CHEST published a Korean screening cohort from Nam and colleagues covering more than 41,000 adults who had chest CT as part of routine health checkups. Emphysema was reported in about 9% of participants, rising from under 3% in never smokers to nearly 15% in current smokers. Among ever smokers, incidental emphysema was associated with roughly a 60% higher risk of death, even after adjusting for pack years. But the authors are admirably restrained. Adding emphysema to a model that already includes smoking improved discrimination by essentially nothing, and in the full cohort, the association did not reach statistical significance, a result they call inconclusive rather than negative, given only 284 deaths. The practical reading is that an incidental emphysema line on a screening report should not by itself drive prognostic counseling once you know the smoking history, though whether it should trigger evaluation for undiagnosed COPD remains open. 2 cystic fibrosis papers round out the imaging theme. In thorax, Dehode and colleagues studied nearly 300 adults with cystic fibrosis before and 12 months after starting elexacaftor-tezacaftor-ivacaftor. Before treatment, about 3/4 of patients had static hyperinflation, defined by an elevated residual volume to total lung capacity ratio. After a year of modulator therapy, that ratio fell by a median of about 5 percentage points, yet it remained abnormal in 65% of patients, including some whose spirometry had normalized. Normal forced expiratory volume in 1 second on modulators does not mean normal lung mechanics, and plethysmography may deserve a place in follow-up. Complementing that, respiratory medicine reported a single-center descriptive study by Girardi and colleagues of lung ultrasound in 35 children with cystic fibrosis using a standardized 12-zone score. Abnormalities, mostly B-lines and small subpleural consolidations, were seen in about 2/3 of children. The score correlated strongly and inversely with percent predicted lung function and with body mass index. Children on modulator therapy had lower scores, and ultrasound picked up abnormalities in just over 1/4 of examinations where the chest radiograph looked normal. Computed tomography remains superior for proximal lesions, so this is a complementary radiation-free monitoring tool, not a replacement, and the sample is small. Finally, 2 thoracic oncology papers. In the Journal of Thoracic Oncology, Wu and colleagues report a multi-center single-arm phase 2b trial of sutetinib, an irreversible epidermal growth factor receptor tyrosine kinase inhibitor, in 99 treatment-naive patients with advanced non-small cell lung cancer, carrying uncommon mutations such as G719X, S768I, and L861Q. The independently confirmed objective response rate was about 71%, disease control about 91%, and median progression-free survival was 13.7 months, with responses numerically better in compound mutations. Toxicity was real, with grade 3 or higher treatment-related events in just over 40%, driven largely by diarrhea, and 1/3 of patients needing dose reduction, though discontinuation was uncommon and there were no treatment-related deaths. This is single-arm data, but it is meaningful prospective evidence in a group historically served by extrapolation. Separately, Thorax published a multi-institutional cohort from Atkins and colleagues of 848 patients receiving thoracic radiotherapy for non-small cell lung cancer. The 2-year cumulative incidence of pulmonary hypertension was nearly 12%, and the dose delivered to the pulmonary arteries, specifically the volume receiving 10 gray, was the strongest predictor, replicating in a validation cohort. Patients who developed pulmonary hypertension were far more likely to have tricuspid disease and right ventricular systolic dysfunction. Discrimination was modest, and the findings are hypothesis-generating, but they suggest a vascular mechanism distinct from radiation fibrosis and a possible new organ at risk for treatment planning. If you only have time for one paper this week, make it the Mepolizumab versus Dupilumab comparison in chest. It addresses a decision that is landing in clinics right now, and the absence of a demonstrated efficacy difference reframes biologic selection in eosinophilic COPD around access, comorbidity, and patient preference. Here are the key takeaways from this week in pulmonary. First, indirect comparison shows no significant efficacy separation between Mepolizumab and Dupilumab in eosinophilic COPD, so choose on practical grounds. Second, even mild home-treated exacerbations track with faster lung function decline, including in Gold A patients, so stop treating them as trivial. Third, fragmented outpatient care is associated with substantially more COPD hospitalization and death, and inequalities by deprivation, sex, region, and ethnicity in England remain wide. Fourth, incidental emphysema on a screening CT adds almost nothing prognostically once you know the smoking history. And fifth, in cystic fibrosis, hyperinflation persists in most adults despite highly effective modulator therapy, while lung ultrasound offers a radiation-free adjunct in children that outperforms plain radiography. That's your roundup for This Week in Pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.